Thank you so much. A very warm greetings and good morning to all the respected dignitaries, professors, all the respected faculties, teachers, seniors, juniors, my colleagues, and your students and everyone present here. It gives me an immense pleasure to be standing here in front of you today and share some insight about a topic that is very close to my heart. And it is also a privilege to be sharing this speaking platform with Professor Dr. Sean. Newborn screening, early detection matters. We all have some purpose in our academic arena. And my purpose as an academician, as a laboratory personnel, is, I feel, to establish or to contribute in the field of newborn screening. My passion to study about newborn screening actually started during my post-graduation day. When I joined as a PG, I was already a mother who had lost her first pregnancy due to a preterm delivery. And I had just recently given birth to my son with a complicated pregnancy. After studying about newborn screening, I realized that my son, who was born healthy, was merely just a miracle, or I would say a blessing, or just a coincidence. However, there are lots of parents who lose their child without even knowing what is the cause behind it. And in most cases, the cause are inborn error of metabolism. When I studied about newborn screening, I realized that it was many newborns in the most part of the world, they are screened for lots of inherited disorders. But unfortunately, newborns born in Nepal are deprived of this facility, of this service, which is a birthright for every baby born. So today, my talk would be just about sharing information, awareness about newborn screening. This is just an awareness talk. However, lots of work needs to be done in this field, and I hope this talk today will motivate each one of us here today to contribute in this field. However, I said that newborn screening is very close to my heart, but there are certain products that are used in this presentation, which I would like to claim that I do not have any conflict of interest, and I brought it just for the sake for the presentation. The objective of my talk today is to communicate the importance of newborn screening as a public health priority to improve the lives of newborns. And to achieve these objectives, my presentation today will be covering the following topic, where I will be giving you all a brief overview on inborn error of metabolism and newborn screening, and talking about various aspects and components of newborn screening. And I will be focusing on one simple, most preventable cause of mental retardation, which is congenital hypothyroidism, and how can we as a country, we can start screening the babies at least with one condition, which could be congenital hypothyroidism, and initiate this program in the country. When we talk about inborn error of metabolism, it all comes back to the year 1908, when an English physician, Sir Archibald Garrod, who was considered as a pioneer in the field of inborn error of metabolism, discovered alkaptonuria and understanding its nature about its inheritance. So he is also known as the father of inborn error of metabolism, and he coined the term IEM, inborn error of metabolism. When we see IEM as an individual disorder, it is rare. But collectively, if we see IEM, it is not rare. We can see that it has an incidence of 1 in 1,000 birth collectively. The pathophysiology of IEM arises from the block in the metabolic pathway due to deficient activity of a specific enzyme. Now here, if we look at this slide over here, this here is the Garrett's hypothesis. Am I audible without the mic as well? So here we can see this is Garrett's hypothesis talking about a substrate being converted to product. We have enzymes in the pathway, and whenever there is block in any of the enzyme, either the problem arises due to the substrate excess, the product deficiency, or the toxic accumulation of toxic metabolites. And based on these pathophysiology, we can classify inborn error of metabolism into three categories. Group 1 as intoxication disorder, Group 2 as energy failure group, and Group 3 as storage disorder. In regards to intoxication disorder, the problem arises due to the accumulation of toxic metabolites, and the disorders included in this categories are amino acid disorder, urea cycle disorder, and organic acid disorder. When we look at the energy failure group, it occurs because of production or utilization problem. And some examples in this defect are fatty acid oxidation defect, PDH deficiency, or respiratory chain disorder. And in group 3, we have various disorders which arises because of the storage of macromolecules, and the examples are like lysosomal storage disease and congenital disorders of glycosylation. Advancement in science and technology has made it possible to fulfill a dream that newborn screening, that health is a human right. And when we talk about health is a human right, there is a program known as newborn screening, which is considered to be one of the most preventive, affordable, very effective, highly beneficial, and this program is accessible in many parts of the world. This technology, known as newborn screening, it is universally accepted public health program for the early identification of disorders that can lead to mental retardation and deaths in newborns. Newborn is about saving the lives of babies, and whether a baby is born in the western part of the world, in high-income country, or whether a baby is born in a low-income country. Newborn screening is the birthright of every baby. But unfortunately, babies born in many parts of the world are deprived of this facility. This image here was used as a publication or used for the Philippines newborn screening program. When we look at this picture over here, this baby who is in the wheelchair has congenital hypothyroidism, and he did not receive newborn screening. And this girl over here has congenital hypothyroidism and was diagnosed through newborn screening. And here she has become an engineer, and this baby here is still wheelchair bound. Here, similarly, this baby who is 15 months old did not undergo any newborn screening for medium chain acyl-CoA dehydrogenase deficiency. And here the different baby who received a newborn screening test, diagnosed for MCAD early in the life, is developing as a normal, healthy baby. And I'm sure there are lots of success stories of newborn screening throughout the world. Now, coming to newborn screening, how do we define newborn screening? Newborn screening is defined as a public health program which is aimed at early identification of conditions for which early and timely intervention can prevent or reduce associated mortality or morbidity in the newborns. It has been hailed as one of the top medical triumphs of the 20th century, and ideally the system should reach to all the newborns. It is simple, inexpensive, yet effective methods to identify pre-symptomatic neonates. How do we collect the sample for newborn screening? This entails a collection of few drops of blood from the heel of the newborns on filter paper. We call this filter paper as dried blood spot collection card, DBS card. And when we look back at the history of newborn screening, it all comes back to the year 1960s, where Dr. Robert Guthrie, he first described about a bacterial inhibition assay to detect PKU as the first newborn screening test to be established and diagnosed. And for his contribution to collect the blood in the DBS card, which is also known as Guthrie's card, he is considered as the father of newborn screening. So the benefit of newborn screening, as you all must have already known by now, is identification, early intervention, reduced mortality, morbidity, and also it helps in the reproductive decision for a couple. If they have a previous baby who has an IEM, it helps in the reproductive decision. But there are certain risks or pitfalls of newborn screening because it will definitely lead to parental anxiety because there are tests which will give us false positive results. There might be misdiagnosed cases because of the false negative test results. There are certain disorders that the child or the parents have the right not to know, and because of the advancement of technology like tandem mass spectrometry, although the parents do not want to know, but there are certain disorders which are diagnosed. We also have this labeling. Suppose if a child has some benign condition, there might be a risk that the child would be labeled with that disorders. And when we look at the inheritance pattern, most of these IEM that we talked has an autosomal recessive inheritance pattern with a congenital hypothyroidism as an exception. Congenital hypothyroidism could arise as a result of autosomal recessive inheritance, but in most cases, it has a sporadic inheritance. Now, looking at the evolution of newborn screening in terms of scope, starting from the early 1960s till date, we can see here that the number of disorders are increasing with the advancing year. Initially in the 1960s, as I already mentioned, from the contribution of Dr. Robert Guthrie, PKU was the first condition to be screened. And now here we can see there are now hundreds of disorders that are being screened in many parts of the Western world. So here, over the last 50 years, newborn screening has followed a natural curve of growth in terms of two parameters. One is increasing number of disorders to be screened and increasing accuracy of the screening results. And evolution of newborn screening in terms of technology. As mentioned earlier, in 1960, it was a bacterial inhibition assay that was being described by Sir Robert Guthrie. But later, as we see advancement in the age, immunoassay technique was used, the enzyme assay was used, and ultimately with the discovery or with the starting of tandem mass spectrometry, it was a breakthrough in the field of newborn screening. And from 1990s, we can see that the focus on selection of disorder has increased, and a lot of technologies have now combined the techniques for the detection of various newborn screening disorders. And now we also see some part of the world undergoing next generation sequencing or whole exome sequencing to detect newborn screening disorder or IEM. Now, when should a country introduce newborn screening? When we talk about Nepal, we still don't have any newborn screening program. So if we look at the WHO guideline or recommendation, WHO recommends that genetic services and screening should be introduced in a country with infant mortality rate less than 50. And when we look at the context of Nepal, is Nepal suitable for starting a newborn screening program? Here, if we look at the population of Nepal, we have a population of 29.8 million and the birth rate of 18.37 per 100. And when we look at the infant mortality rate of the latest 2024 report, we see that the infant mortality rate is 22.71, which is definitely less than 50. So Nepal is definitely suitable for starting a newborn screening program. This concern mainly arises because we have been seeing the change in the trend of infant mortality rate. Initially, the problem was because of the infectious disease, but now congenital malformation and genetic disorders are gradually replacing the infectious cause of perinatal mortality and morbidity. So Nepal is suitable to introduce a newborn screening program. Now, which tests to introduce or what are the criteria for newborn screening? Which disease to be included? It depends on country to country because there are 10 criteria which was given by Wilson and Younger in the year 1968, and most of the country, they rely on this criteria to introduce a test or to screen for any new disorders. And here, if we see, this criteria is gradually evolving, but this Wilson and Younger's criteria for screening has remained constant. The condition that we should include in newborn screening should have an important health problem. It should be an important health problem. The incidence and natural history must be understood. There should be a recognizable latent and early stage of the disease that we are planning to include in the newborn screening. There should be available suitable screening test or examination, and it should be acceptable to the population. There should be an agreed policy on whom to treat, accepted treatments available. The facility for diagnosis and treatment should be available, cost effective for diagnosis and treatment, and continuing process. Newborn screening should be a continuous process, and it should not be once and all for all project. So considering these 10 criteria based on the incidence, the natural history, and all these criteria, the country can choose its own test or own disorders to be considered in their newborn screening program. So that was in regards to disease, the criteria for the disease selection. Now, what would be the criteria for the newborn screening in terms of testing? What are the technologies? What kind of tests should we consider when we are talking about the newborn screening program? In regards to diagnostic methodology, the method that we will be using to detect newborn screening, it should be simple. The sample collection should be simple sample collection, and it should be amenable to dried blood spot. There should be an easy collection and transport technique. The test should have high sensitivity with less false negative rate, high specificity with few false positive, high throughput methodology, and it should be cost effective. And definitely it should have a available quality control and proficiency testing programs available. And with the, as I told, with the advancement of tandem mass spectrometry, the test should be able to perform on a multiplex platform. Now, these were the criteria for the test in regards to diagnostic methodology. And once we get certain tests positive from this test here, we need to have a confirmatory test available for the test, which is positive in the screening. And these confirmatory tests should be easily available, and the results should be rapidly available to the parents so that there is no delay in the diagnosis and treatment. So newborn screening is actually not just a disease or a condition where only one group of specialty is taken care of. It should be a multidisciplinary team approach. We have different specialties that are included in the newborn screening. There are certain diseases like metabolic disease over here, metabolic disease like galactosemia, biotinidase deficiency, adrenoleukodystrophy, Pompe's disease. We have disease which comes under the pulmonary specialty like cystic fibrosis, disease which comes under hematological specialty like sickle cell disease, hemoglobinopathies, and SCID. We have endocrine disorders like congenital hypothyroidism, congenital adrenal malformation, hyperplasia, and there are certain disorders which are under the neurological specialty like spinal muscular atrophy and other disorders like congenital hearing loss and critical congenital heart disease. So it is a multidisciplinary team approach that comes together as a team to solve this newborn screening disorders. Now, we saw the criteria, we saw what are the criteria for test and diagnostic. Now, there are things where we as country, where do we start? How do we start? So we cannot directly maybe go to the tandem mass spectrometry technique to bring in newborn screening in the country. So there are countries like India from which we can adopt this newborn screening, how they are doing in terms of newborn screening. So we can categorize this newborn screening as basic newborn screening and expanded newborn screening. So the basic newborn screening program varies from country to country, depending on what are the available infrastructure in that country. Now, if we look at in the context of India, the India has a core screening usually which includes 7 different disorders that they have included, like congenital hypothyroidism, congenital adrenal hyperplasia, G6PD deficiency, galactosemia, biotinidase deficiency, cystic fibrosis, and sickle cell anemia. When we look at the diagnostic protocol for these testing, it is a simple biochemical enzymatic assay. We do not need a highly sophisticated infrastructure to conduct this basic newborn screening program. However, the expanded newborn screening, where we can see the disease under the expanded newborn screening are diagnosed either by tandem mass spectrometry or other sophisticated technologies here. And the disorders that we are screening here comes as amino acidopathies, organic acidemias, fatty acid oxidation disorders. But what are the disadvantages when we talk about this expanded newborn screening is it is an expensive test. It needs reference lab to confirm these disorders, and only few experts are available in the country. And moreover, once we diagnose these disorders, the treatment, like whether it be a dietary modification, like for PKU and all, we need to have a phenylalanine-free milk for the baby. These treatments are not available and is expensive. So these all comes under the expanded newborn screening program. So as I already mentioned earlier here, these are the 7 basic disorders which are screened, which can be considered, and we can follow this to start from in Nepal, because these are the tests which can be performed by simple biochemical and enzymatic tests. And here, as I mentioned, these are the expanded tests. So with the evolution, with the tandem mass spectrometry methodology, it has revolutionized the field in late 1990s by enabling detection of many inborn error of metabolism with minimal extra effort or cost. Here, with a single drop of blood, more than 40 disorders can be detected from a single test. So this technology is expanded to encompass various disorders. So now coming to newborn screening as a public health program. When I talk about newborn screening, it is not simply a test, but newborn screening is a system, it is a program, and it is considered as a public health program. And when we look at this newborn screening as a public health program, if we look at the context of United States, here, they screen over 4 million infants in US alone each year. And it is not just a testing or a screening, but they comprises the follow-up of the baby, the confirmatory diagnostic of the test for the disorders that they are diagnosed through screening. It involves the disease management, the program evaluation, and also the quality assurance. And when we look at in US, it is a state health department initiative. And in India, the Indian Council for Medical Research initiated through the Task Force on IEM Disorder, a program to screen neonates in 5 centers. This ICMR, they involved 5 different states over here, India, Delhi, Mumbai, Chennai, and Hyderabad, and they conducted a pilot project to screen for the various 7 disorders that was mentioned earlier from the year 2007 to 2012. And they were successfully able to screen um, uh, babies for congenital hypothyroidism. Here we can see the incident as high as 1 in 1130 and congenital adrenal hyperplasia as 1 in 5762 babies. So it is a public health program, and it is not just a test. So there is a recommended uniform newborn screening panel, which has been followed in most part of the United States. It is a list of screening disorder which has been recommended by the Secretary Department of Health and Human Service to the states in the United States based on the advisory committee recommendation. And these disorders here in the recommended uniform screening panel, which we call as RUS, it currently involves 35 core conditions and 26 secondary conditions included. And it is mandatory that every state in the United States has to at least do this RUSP in their state, and the other tests which are being added, it depends on the state manner. So if you want to go and learn more about this RUSP, you can visit this website where they have included all these 4 conditions and the secondary targets and the disorders which are included. And again, looking at the current state of newborn screening in India, these were the 7 disorders that was suggested under the universal screening program that was conducted for 5 years. And now currently, Chandigarh, they screen for congenital hypothyroidism, CAH, and G6PD. So all the newborns who are born in Chandigarh, they have these 3 disorders screened through the state-wise level. And Goa, they screen all the babies for CH, congenital adrenal hyperplasia, G6PD, galactosemia, cystic fibrosis, and biotinidase. And Kerala, they screen for congenital hypothyroidism, CAH, G6PD, and galactosemia. What about the status in Nepal? If we look here, there was a pilot study which was done in the year 2019 by Dr. Aarti Pandey here. And here we can see that in this program, 5,000 samples were collected from Kathmandu Medical College and IOM. And this study identified, they sent the sample to Switzerland in the DBS card. And this study, the cases identified were 2 congenital hypothyroidism and 1 cystic fibrosis patient. And here, recently in the year 2024, there has been an article published where the study was about regarding the feasibility of clinical newborn metabolic screening in a high volume maternity center in Nepal. So this study, they collected 825 samples of the newborn from maternity Pakar hospital. And here we can see out of this 825 babies that were collected, there were 13 reports which were abnormal. Here we can see 5 hemoglobinopathies were detected, 3 congenital hypothyroidism, 2 G6-PDH deficiency, 1 CAH, 1 elevated acylcarnitine, and 1 biotinase deficiency. So we can see that the IEM, the inherited metabolic disorders, are not rare in Nepal. We can see the babies, there are babies who miss the chance of being diagnosed. So newborn screening, as I already mentioned, is not just a test. It is a successful program. It just not comprises that we are just collecting the blood and then testing and then, okay, this is positive and not. It is a complete successful program. And here there is an article which highlighted the newborn screening more than merely just a testing activity, and it has 7 components. And it all starts with education, with awareness of the parents, first of all, because they are the one who will be giving consent for the sample collection of their baby. So education of the parents and the public regarding the purpose, utility, and benefit of newborn screening. The starting point is first education and awareness. Then when we screen the babies, it involves not just the sample collection, because we have if we plan to start a newborn screening, we will definitely have very less referral center. So it should comprise sample collection, transport, testing, and storage of this filter paper specimen. And diagnosis consists of result assessment result by person with appropriate training and preparation of the report. And when we convey the reports to the parents or the doctor, it should be done immediately by telephone if there is an abnormal report there, because we don't want a single day to be delayed for the starting of the treatment of that baby. And if the report is normal, the parents has the right to know that their baby has tested normal. So we should do that by mail. And whenever there is a positive result, we need to provide counseling to the family immediately. And once we have diagnosed and then call the baby, it's not just that you diagnose and then you say the baby that this is the condition. We have to have a follow-up program if the results are positive, which comprises recalling of the patient, repeating of the test, confirming the diagnosis by biochemical or DNA analysis. And talking about management, it comprises treatment, periodic examination, and monitoring of long-term outcome in the babies, and monitoring and evaluation of program to quality assurance, outcome, and effectiveness. So unless we have a proper quality system or quality control program or a proficiency testing, we would not be able to give a standard quality report to the baby. So as I mentioned, it's a complete process starting from the birth of the baby here, and then the filter paper collection starts over here, and the sample is being transported to the screening laboratory, and then there will be the integration. Once the reporting is done, there will be the integration of the data into the database, and they are informed to the counselor, the geneticist, and the newborn tracking. Now, the sample which comes is positive, we need to track this babies, and then immediately we need to call this baby for confirmatory testing. And then ultimately they are referred for management to the tertiary medical institution. So it is a complete process and not just a test. So when is the ideal time for a sample collection? When do we do this newborn test? So the ideal time, if we look for the sample collection, is after 72 hours of birth of the baby, within 7 days. But what is the main problem when we say 72 hours? We see that this policy is difficult to adopt because of the high birth rate in the hospital. We have limited space in the hospital. So most of the baby, they are discharged early within 24 to 48 hours. So in that case, if the baby is being discharged early, we can also take the sample at 24 to 48 hours of life when the enteral feeding has been established. And there has to be an individualized recommendation regarding the screening, example, the timing and the number of the studies for especially the premature or sick baby, because when the baby is premature or sick, we might not get the proper result at that time. So we need to have this individual recommendation. And there should be a special consideration, especially for prematurity, illness, the total parenteral nutrition. When the baby is already on an IV drip, we need to be sure that we are not collecting sample at that time, because certain amino acids and organic acid may be elevated in such sample. Whenever the baby is going transfusion, it is always ideal to collect the sample before the transfusion. And if the baby is being discharged early, the parents should be advised to come again for the testing. And where and how do we collect the blood sample? As I mentioned earlier, we have this Guthrie's newborn screening card that from where, and here we can see the heel prick is done on the lateral side of this heel, which is marked here black. And then a lancet is used to make a prick, and we collect drop by drop of blood in this filter paper card. And Professor Sean has been very kind enough to bring a sample of newborn screening card over here. So if you want to have a look at it, this is a DBS card, which has all the information over here of the mother and the baby. So all the informations are recorded in this card. And once we take this blood sample in this card, we punch this blood through a puncture, which could be automated or a manual puncture. And we keep it under various techniques to be tested further. And here are some of the example of improper sample collection. Here we can see that this sample here is insufficient, this sample here is diluted, this sample here is super saturated, this sample here is contaminated, and here the sample has a serum ring, which is also considered as an inappropriate sample. So we need to train the staffs to collect this, to perform a heel prick and collect the dried blood sample. So as I mentioned, once we collect that sample in this DBS card, there are various techniques which can be implied for the testing, like visible and fluorescence enzymatic assay. And then colorimetric assay, we can use it, the same sample in the tandem mass spectrometry, electrophoresis, HPLC, real-time PCR, immunochemical and molecular assay, and also in next generation sequencing. So this card here, in which we collect the sample, we can use the same sample to be applied in all the sophisticated technologies. So the challenge here remains that the laboratory must maintain highest level of qualities in their testing while identifying all the affected newborns with minimizing false positive. And in the US and most part of the Western world, they have this assurance of the quality in the newborn screening is done through this newborn screening quality assurance program, which is conducted under the wings of CDC. Now, here, one of the techniques or one of this thing that newborn screening is widely used, because I had an experience of seeing this newborn screening program run performed in India, and they were using this Perkin-Elmer Delphia system, which used time-resolved fluoroimmunoassay technique, and all the 7 basic parameter that I mentioned earlier can be performed with this one simple machine. So this is a Victor 2D fluorometer, and which is accurate, precise, high positive predictive value, highly sensitive and specific, and far superior to ELISA platform and most trusted system for newborn screening. And if we see, it is not just a thing, they have a whole range of this, where we, starting from the newborn screening card till the sample, the puncture is there. There's an automatic puncture, the plate shaker, and also it's entirely, they have a system, the semi-automated system for the screening program. So when we report the result of the newborn screening, what we need to know is newborn screening, the reports, they are not diagnostic. They are just a screening test, and they are not comprehensive. And disorders detected by newborn screening actually represents only a small fractions of the IEM. And the reports are either reported as a normal result, they are either reported as abnormal result, which is given as a presumptive definitive diagnosis, or we get a report as unsatisfactory specimen. So when there is normal result, we test the reporting to be normal. But when there is a presumptive definitive positive result in the patient, in the newborn, we need to call the newborn immediately as a situation of urgency to confirm the diagnosis, to confirm the testing. And whenever there is an unsatisfactory specimen, the testing is performed and the results are reported with a note that the specimen was unsatisfactory. And we need to repeat the collection in such scenario. So once the report is available, what next? We need to communicate the result to the parent as early as possible. And positive results from newborn screening should always be followed by a confirmatory test performed as quickly as possible. And we must remain vigilant to the development of the disease, because a negative result does not rule out the disorders, even if the screening is performed appropriately, because there are cases of false negative reports. So just because a newborn screening is negative will not rule out that the child does not have any IEM. So the vigilant about the disease, the symptoms should always be there. Now, once the initial screening is positive, we have a second tier testing, which is performed when the initial screen for specific disease is positive. And these second tier testing should be tests which has a rapid turnover time, because these are the confirmatory tests, and we don't want the confirmation to be delayed, because each day, each hour that is spent in delay will have an adverse effect on the health of the baby. So the commonly used example for the second tier testing is for tyrosinemia type 1, we measure succinyl acetone if tyrosine is elevated in the first year testing. And for congenital adrenal hyperplasia, we can measure 17 hydroxyprogesterone or steroid profile. Initially, we were doing it by the enzymatic method, but in the second tier testing, we do the same test by the tandem mass spectrometry. And for galactosemia, we can measure galactose 1 phosphate is GALT enzyme activity is low in the first year testing. So there are 10 components, there are 10 steps in the newborn screening recommended by WHO and also by the Indian Council of Medical Research. Here, the newborn screening first always starts, as I mentioned earlier, with education, awareness, and especially advocacy. We lack this system in Nepal. We don't have any advocacy agents or advocacy group who are advocating for the newborn screening implementation in the country. There should be an institutional ethical committee who would be looking at the ethical guideline to initiate the newborn screening. There should be a blood sample collection, filling of the NBS card, transport of that DBS card to the laboratory facility. Analytical protocols should be present with the proper SOPs, data entry and analysis, reporting of the test and recall, confirmatory test, and management protocol. So all these should come together as a program whenever we plan to initiate or start with a newborn screening in the country. So a successful newborn screening program requires a suitable test, a laboratory quality standard, availability to all, because equity matters and equity for the general impact. So this test should be available to all. Effective follow-up, as it is not just a test, but it is a program. There should be rapid access to the treatment, and newborn screening should be legislatively mandated as a universal public health program. And the government should come together in helping this newborn screening to be built as in the policy of the health system of the country itself. So we all belong to laboratory, and laboratory is a vital component of the newborn screening system. So as laboratory, we need to be able to conduct high quality screening covering all the mandated tests, communicate with other component of the newborn screening, because once the report is available, it is the laboratory personnel who will be communicating the report to the patient or the physician. It plays a key role in translational research by defining and designing new laboratory tests, and it is committed to continuous quality improvement. So if we want to have a vision of newborn screening for Nepal, we need to train all the pediatrician and laboratory personnel and community health workers regarding comprehensive universal newborn screening and dried blood specimen collection. And we need to plan for logistic for transportation of the DBS card. We need to have modules for management of positive sample. We need to have support system for any queries or queries regarding NBS, and we need to be able to provide information and data collection, analysis, and corrective actions. So we can have this as a planning for or a vision for starting newborn screening in Nepal. Now, I would just like to talk just a brief introduction or overview or just few slides about congenital hypothyroidism. Congenital hypothyroidism is defined as the deficiency of the thyroid hormone at birth, and it is considered as the most preventable cause for mental retardation in newborns. And we can see here, if the congenital hypothyroidism is untreated, these are the symptoms that the child may manifest with. And here we can see the symptoms over here, like there's prolonged jaundice, there is a coarse facial feature over here. Now, with this baby boy, he is 2 years old, and he has delayed development, he has constipation and coarse facial feature. And this boy came to notice at the age of 2 years, and it was late. So if we diagnose the CH, it should be as early as possible within 14 days. If CH treatment should be started, it should be started before 14 days of life to get a near normal intelligence in the baby. So what is the rationale behind congenital hypothyroidism screening? Here we can see in India, which is quite close to our context, the prevalence is as high and in 1 in 750 birth. Only 5% of the babies are symptomatic at birth, and 95% babies, they do not have any symptoms, and we miss testing the babies. And screening method for TSH is very cheap and easily available. It is highly effective and relatively inexpensive. And if we see here, if we are diagnosing the baby within first 3 months of life, we can see a mean IQ of 89. But again, if that diagnosis is happening beyond 6 months of life, we can see the IQ being reduced to as low as 25 to 80. So earlier the diagnosis and treatment initiation, the IQ of that baby can be preserved. So how do we screen? We have a TSH-based screening method, which is highly adopted method. But when we are using the TSH-based screening method, there are chances that we can miss the central hypothyroidism, or we can also miss delayed TSH elevation cases. Or we also can do a T4-based method. T4-based method. Here, the T4-based method can miss the compensated subclinical hypothyroidism case. And we can use both TSH and T4 as a screening method, but this is expensive. So most part of the world, they are following this TSH-based screening method for congenital hypothyroidism. So we can also collect the blood sample from the cord blood or the DBS sample. Here, this cord blood, immediately after the baby is born, we can take the sample from there. So it is a painless technique. It can be done to all the babies, and it is not affected by this TSH surge phenomenon. There is a rapid rise of TSH immediately after the birth within 30 minutes of life, because the baby is exposed to a cold environment after delivery. So whenever we are taking the blood from this cord blood, we can minimize the TSH surge effect. And the disadvantage of this cord blood sample is the nursing staff and lab people should be ready at any time immediately after the delivery. But if you look at the heel prick test, which is the commonly adopted method for the sample collection, here, although because we are taking the sample from the heel prick, it is a painful process, and the affected here we can see some babies may be missed because once they are delivered, because of early discharge, we can miss some baby. And here, one difference is whenever we are taking cord blood, we can only test TSH in that sample. But when we are taking the DBS sample, the same sample can be used for multiple tests. So definitely DBS card has an advantage of testing more tests when we take the sample through the DBS card. So this is an approach to the elevated TSH. Whenever the TSH level is more than 20 MIU per liter, either through a heel prick or cord blood, we recall the baby and we do a total T4, free T4 and TSH again. We repeat the test. Now, in the repetition of the test, if the TSH value is between 20 to 40, we recall the baby again in the second week of life, 7 to 10 days, because we want to rule out the TSH surge in this phase. But if the TSH is more than 40 in this first DBS sample, we immediately recall the baby. We don't wait for till 10 days. Within 72 hours, the baby is called. Now, when the baby is called, we go for a physical examination and we take now confirmatory venous blood sampling. Initially, for the screening, we had taken DBS sample, but for confirmation, we need to collect the venous blood sample for T4 and TSH. And when in the sample, the TSH is more than 80, we do not wait for any confirmation test. In this case, when the sample TSH value is more than 80, we do not wait for any confirmation test and we directly start the treatment here. So here, if the level of free T4 is less than 1.1 nanogram per DL, or if the value of total T4 is less than 8, and if the value of TSH is more than 20 or more than 10 beyond 2 weeks of life, even after 2 weeks here, when we are calling the baby, the value of TSH is more than 10, then we start the treatment in this baby. Here, similarly, if there is a persistent elevation of TSH more than 10, but even if T4 and T3, free T4 and total T4 is normal, we start the treatment because this might be a case of transient hypothyroidism, and we start the treatment and reassess the baby, follow up the baby and reassess them until 3 years of life. And the treatment is very easily available. We just need to crush the thyroxine tablets at a dose of 10 to 15 microgram in the breast milk or the water, and we give the baby. So we can see just by a simple test and simple treatment, we can prevent this mental retardation in the baby. So here's some summary that I would like to highlight, that WHO has recommended to start the genetic service and introduce screening in the country with IMR less than 50, and Nepal is definitely ready to start a newborn screening program. Newborn screening is not just a test, but it is a public health program which saves life, prevents disability, and saves money. But without data, it is very difficult to convince and get support from the government to build newborn screening in the policy of the country. Hence, it is necessary for the pioneer to come up with projects that can provide data to the government for screening of newborns in the country. The earlier we screen, the earlier we can start the treatment and prevent the lives of the newborn. And negative NBS test does not rule out IEM. And to begin with, in Nepal, we can start with the universal screening for congenital hypothyroidism. And talking about Nepal, so IFCC is planning or willing to help in certain aspect to start newborn screening in terms of education, in terms of providing support to Nepal. And but all they want is, they want a group of people to come together. They want us to form a society, a committee, including pediatrician, the government people, to come together and form a group, and then they are willing to guide us with the newborn screening programs to be started in Nepal. So we all can work together to establish this program in our country. I would be happy to answer any questions if there are any, to the best of my knowledge. And I would like to end here saying that a baby saved is a generation saved.